Hello, everyone, and thank you for joining International Medical Corps for our COVID-19 learning series, which is comprised of 5 webinars on the most critical aspects of the coronavirus pandemic. Today's final webinar in this series will focus on medical surge. We know how busy you all are with your organization's response, and we really appreciate the time that you're spending with us. My name is Maura Buchter, and I'm the Deputy Director for Learning and Engagement at International Medical Corps. This session is being co-facilitated by my colleague Ryan Bresnahan, and Ryan is our Training and Operations Officer in our Emergency Response Unit at International Medical Corps. Now I'd like to introduce our great speakers for today's session on medical surge. We have 2 frontline medical professionals with us today to look at different levels of surge capacity. At the macro level, Amanda will look at how local, state, and federal jurisdictions coordinate on medical surge. At the micro level, Lindsay will share how a large tertiary care facility is preparing for increased surge capacity. About our speakers, Amanda Ramsdell currently works as an emergency department nurse at UConn John Dempsey Hospital in Connecticut. She is deployed with International Medical Corps to Florida in response to Hurricane Michael and to the Bahamas in response to Hurricane Dorian. Amanda has also served over 24 years in the U.S. Army and has deployed multiple times in support of military operations and to St. Thomas to assist with relief efforts. Amanda is currently working on active duty to assist in the global pandemic of COVID-19. Lindsay Martin is Director of Mass General Hospital's Global Disaster Response and Humanitarian Action Program. She has her BA in International Relations from Hamilton College, as well as a bachelor's and master's in nursing from Northeastern University. Lindsay is trained as a critical care nurse practitioner with a focus on surgical critical care and trauma. After starting her NP career at University of Maryland Medical Center Shock Trauma, she joined the Blake 12 Surgical ICU at Mass General in 2015. Lindsay's work in disaster response began at the same time as a volunteer on the Global Disaster Response Team when she deployed with MGH to the 2015 earthquake in Nepal. She has assumed the role of team leader on many international and domestic deployments, most recently in the Bahamas with IMC, as a clinical lead in the MGH COVID Respiratory Infection Clinic. So we're really excited about our speakers today. But before we get started, I'd just like to tell you a little bit about International Medical Corps. We are a global humanitarian organization dedicated to saving lives and relieving suffering. Established in 1984 by volunteer doctors and nurses, we're a nonprofit with no political or religious affiliation, and we now have more than 7,000 staff members around the world. More than 90% of our staff members are local to the countries where they're working. Our mission is to improve the quality of life through health interventions and related activities that strengthen underserved communities worldwide. With the flexibility to respond rapidly to emergencies, we offer medical services and training to people at the highest risk, always working to strengthen local healthcare systems and promote self-reliance. In alignment with our mission, International Medical Corps is responding to the COVID-19 pandemic around the world, deploying medical supplies, training health workers, setting up triage and screening sites, and more. Together, we're ensuring that people receive the medical care they need while keeping health workers safe. Right now in the U.S., International Medical Corps is increasing patient capacity at hospitals. We're delivering training and information series for health workers, and we are ready to deploy emergency medical teams. So I would now like to turn it over to Amanda for her presentation, a top-down look at the medical surge response to COVID-19. Over to you, Amanda.
Thank you so much, and thank you, everyone, for being part of this lecture series. I'm going to go over a top-down look at the COVID response here in the United States. As most of us know, COVID became a federal disaster on March 13th, 2020, thus marking a huge undertaking for the federal government and the emergency management system. The federal government relies on the organization FEMA, the Federal Emergency Management Agency, as well as the Department of Health and Human Services to take the lead on this pandemic. They're looking at how they can service the whole of America by the medical resources and medical response that they have within their framework. FEMA gets involved at a different level, and when the president and other state leaders decide to make a major declaration or a state declaration or a presidential declaration, those each step delineates different supplies and services that are available to the states. As we know, this pandemic started in China and hit England and Italy very hard. Our presidential leaders and our state leaders took note of this impact and were preparing for how it was going to start within the United States and the impact that it was going to have. When you start looking at how individuals respond to a disaster, every disaster is based at the local level. So when Corona started impacting the states, the state leaders with their local health and human services got together and realized that this pandemic was going to impact them above what they had within their capability grasp. So as it started to spread, the leaders got together and looked at what they had, knowing that they would not have the ability to adequately medically manage the number of patients they were going to see. The governors went to the president for these declaration statuses. As I said, they all start at the local level, and they all start and end there. So FEMA's and the government's stance is they want to assist local to get back to being able to maintain at local. Medical hospitals, emergency management agencies, and health and human services, through a normal standard, a normal protocol, normally go from the state, the local level, to the state level. States, during a non-pandemic time, normally can use what's called the EMAC, or Emergency Management Assistance Compact, to be able to assist other states in time of disaster. We see this used a lot when you're dealing with tornadoes and hurricanes and natural disasters, because not every state is impacted. Connecticut may be impacted, but California is not, or Pennsylvania is not. On a non-pandemic scale, what happens is local leaders go to the state leaders go to other states. The problem that we're seeing with this pandemic is the normal process of EMAC and the state agreements is not applicable because each state is being impacted by this pandemic, and each state is coming across the same shortfalls that they would have during that type of disaster. So once the local officials go to the state officials go to the governor then goes to the president and says, these are my shortfalls, this is what I need. So looking at it from a top-down approach, FEMA has been receiving these shortfalls from the states. FEMA works at the state and local level to try to source and backfill exactly what those shortfalls might be. In turn, they use local contractors, federal resources, and the part I've been playing a role in is the DoD, or United States military's capability to respond during this time. During the COVID response, FEMA has been inundated with requests. They go from the regional offices up to Washington, D.C., up to the national headquarters in order to source staff and make sure that the whole of America is being looked at when they're looking at sourcing and staffing and being able to make sure everyone gets exactly what they're requesting. Common shortfalls that we're seeing in a lot of the requests that are going to FEMA have been PPE, which I know International Medical Corps did a series on earlier. PPE has been a huge shortfall, and the fact is every state asking for these supplies has diminished the national stockpile. The national stockpile was designed in order to provide a back source to the local levels in time of disaster. But with 50 states and territories all asking for the equipment, the national stockpile has been depleted and continues to go down based off of the requests. Ventilators have been a huge issue as well. There are so many ventilators within the stockpile, so many ventilators that FEMA has access to, and those are being allocated based off of strict guidance of need, requirement, and factual data. ICU beds, again, also go with the same request. There's only so many beds within a facility that the hospitals, state and local, have, but they're looking at creating medical surge locations to staff either acute care, tertiary care, or convalescent care. With all of those things in perspective, a lot of those things are items, but one of the other things that goes along with that is the staff to be able to maintain the equipment, the sites, and the locations. So a lot of those things are becoming struggles because you can make more ventilators, you can contract for more PPE, you can look at other locations, but staffing has really become an issue because as much as you want to, there's only a certain number of medical individuals within our society, and moving those medical individuals from one location to another to assist fills an interim gap, but it also then creates a shortfall within the community that they were taken from. So we're going to look at the different types of medical surge locations that the FEMA and the state and local governors have been implementing within this historic pandemic. Medical surge locations can be broken down into different types. They can be looked at as alternative care facilities, emergency triage surge locations, and tertiary locations. A lot of the acute care facilities are also turning a lot of their facilities that haven't been up to date or haven't been staffed because they have new facilities in place. Here in Connecticut, the Bennett Cancer Center is pictured here, is a center that's attached to Stanford Hospital that was no longer being used. So FEMA sent a contractor in. They can send USACs in, which is the United States Corps of Engineers, in, or local contractors to make sure the facility is up to code and up to need of exactly what needs to happen. So, example, the Bennett Cancer Center here, contracted through FEMA to have the facility increased to be able to handle the COVID-type patients. The National Guard went in and revamped it along with USACs to be able to bring in beds, new oxygen equipment, certain medical staff, medicines, and staff to be able to open this facility to be able to treat COVID patients. The Bennett Cancer Center here in Stanford is actually being organized and ran by the United States military. The United States military sent a urban medical task force down to Stanford last week, and they're actually accepting their first patients this coming week, allowing for an additional 89 beds within Stanford Hospital to be able to manage the subacute COVID positive patient. Alternative care facilities are another area that is being looked at for medical surge. Alternative care facilities are facilities that are detached from medical hospitals or centers, and they're being set up to hold medical convalescing COVID positive or COVID negative patients. Alternative care locations are normally pre-designated by the governors and the state and local officials prior to a disaster as sites that might be used. This picture is of the Connecticut Convention Center, which has been changed into a alternative care facility. It's going to be open and it's going to be hosting 250 beds, staffed by Connecticut National Guard and Connecticut nurses. They set it up to be a COVID positive location, and it's going to be for convalescing care. In addition to medical surge facilities, alternative care locations, FEMA, in conjunction with the military, have deployed and activated these systems called field medical systems. There are 12 FMSs within the United States. DoD has these allocated to different locations in order to help maintain the surge of patients that may come through. An FMS system is not an acute care facility. As you see in the picture, this is the Connecticut Guard setting it up in the CCSU auditorium. These facilities are used for the medical surge patients that are being discharged from the hospital, but still are not capable and ready to go home. A lot of the surge problems not only are happening within the ICU, as Lindsay will say, but they're also happening when you're looking at discharging a patient from the hospital. If you're going to discharge a COVID positive patient who doesn't necessarily need acute care medical anymore, where we're sending them to is becoming a huge issue. I personally work in an emergency department, and we get some patients that come in from assisted living or skilled nursing facilities, and they may be COVID positive. Those skilled nursing facilities are protecting their current residents and not taking back these COVID positive patients. So when we're looking at medical surge, we're looking at it from not only the influx of acute care patients that are surging the hospital, we're also looking at it at the level of skilled nursing facilities and medical surge for those ongoing care management issues that need to happen. The FMS systems are used great for these these additional sourcing of medical patients. They can be used for homeless shelters. Down in New Haven, they're setting up a medical system for homeless, because that is also another population that we have to watch during a surge time, because they have nowhere to go. So we talk about what patients are at what levels and what can happen. This is the file that is in the file box down below. This is an active document that is being used out in New York City, and it's looking at the 3 S's: staffing, supply, and sourcing. A lot of those are what is going to differentiate upon where a patient can go during a surge and where they should go based off of what the facility can handle. If you pull the document up, this is what's actually being used at the Jarvis Center in New York City to say if a patient can go there or if a patient can't go there and they need a different level of care. So the red is the intensive care, which is going to be our acute care patient that needs the most supplies, the most staff, and the most space. Going down within the levels, a lot of your alternative care facilities can take a green, a level 4 or a level 5 or a level 6 patient. Your FMS systems, as I briefed earlier, are those systems that don't have a lot of medical staff. So those are going to take your 5 and 6 level patients. So this matrix has been very helpful that New York designed, because it's creating consistency across the board for those surging patients of what to do with them when they have been discharged and where that those additional surges are going to happen within our medical facility. International Medical Corps has also filled a gap. The federal government can set up these alternative care locations or these emergency triage locations, but staffing is an issue. They have supplies, beds, tents, things like that they can set up adjacent to these locations, but the staff is what's really becoming a huge shortfall within the medical community. International Medical Corps is an example of one of those non-for-profit organizations that can deploy its medical staff for a fast need to those locations on standing structures already or newly built structures within the community. A lot of problems from the federal level when we're looking at medical surge and medical surge facilities. A huge area that has been brought up is, do we set these facilities up to treat COVID patients or non-COVID patients? So when you're looking at medical surge, you're also going to have those patients that still require medical care that are not COVID related. You're still going to have those patients that require skilled nursing and tertiary care that aren't affected due to this pandemic. So the Corps of Engineers and FEMA have been really looking at whether they're going to set these facilities up to be COVID or non-COVID. Within a lot of the medical surge areas, they have actually looked at converting the facilities to COVID positive patients. what New York, a lesson learned out of New York, is you could have these facilities set up to be non-COVID patients. However, if you get one patient in that is COVID positive, it takes that facility from being non-COVID to COVID. Another issue with the medical surge that the military and the FEMA has been facing is the acuity level. We have this matrix which outlines it really nice, but you have non-medical individuals that are setting up and are in charge of the military's perspective of these facilities. They are heavily relying on the chart and those medical sourcing staff members to be able to say what patient should go and what patient shouldn't go. Because we want not only what's best for the patient, but we want what's best for the facility. In addition, who's going to hold these medical licenses for these facilities has also been a dilemma that the state and local have been having a problem with. A lot of hospitals are standing up and extending their licenses to cover these facilities. However, that then puts them at risk as well. So the hospitals are not only then staffing and managing and licensing their facility during a surge time, they're also doing these acute care and tertiary care facilities that's creating a lot of strain within the system. Supplies. A lot of these facilities, like the field medical system, come with an initial setup. But as the burn rates increase and as the need increases for PPE and other medical supplies, where is that back sourcing coming from? As I stated before, FEMA has been pulling from the national stockpile and has been pulling from their state and local stockpiles to backfill and to source these products. But when you look at them, that's only going to last for so long. There's only so much within the national stockpile that can be pulled from. So supplying these facilities is also becoming a struggle. And staffing, where do you get the staff from? How do you make sure that the staff is safe? And how do you make sure that the patients are cared for within the staffing ratios that you may have? Working with the military, I was on a call this morning. I was actually referencing Lindsay. We're setting up the DCU Center in Worcester, Mass. As an alternative care location. The staffing ratios for those level of care of patients is becoming an issue because what FEMA and the government is saying is a safe ratio, the medical staff within the facility is not. So ratio staffing, requests for more staffing is also something that needs to be looked at when you're looking at the medical surge macro level of the system. So again, it starts at the local level and it ends at the local level. As soon as the federal government starts deploying resources, you always look at how soon we can pull those resources back and turn it over to a community. Within this pandemic, that has been a huge issue. The dates of the surge are being analyzed using data received from hospitals, different matrix that are being developed. And the surge and how long this is going to happen keeps shifting to the right. As that shift keeps happening to the right, more patients are becoming safe, but yet the staffing and the supply needs are still becoming a huge demand. So the medical surge continues, and it's going to become more of a long-term game than it is necessarily a quick, short, instant fix. So that's also putting strain within the FEMA system and the government's response. FEMA has been a huge proponent in staffing and sourcing and making sure that at the local level they have the needs that they want and need for those patients. It is an ongoing battle every day. Many conference calls and debates and questioning is all happening but behind the scenes. So I would say just make sure we're all looking at the possible feat that could be happening at the top level, working its way down to the local level. As an emergency department nurse, I will say at UConn, we are set up with a medical surge tent outside for triaging our COVID positive patients as the surge starts to increase. We will be using the tent to triage those COVID positive patients that come in And from there, we will be sourcing them to either the emergency department fixed facility for more care, or to hopefully some of these alternative care sites for lower care as they continue to heal and progress from the disease. But at this time, I'm going to go ahead and turn it over to Maura.
Great. Thank you so much, Amanda, for your presentation. Medical surge locations, alternative care facilities, field medical systems, and how they all become operational. I think it's safe to say that we all learned a lot during your presentation, so thank you so much. At this point, I'd like to turn it over to Lindsay for her presentation, Building Surge Capacity in Boston. Over to you, Lindsay.
Hi, thank you, Maura, and thank you, Amanda, for your presentation. Actually, Amanda and I were in the Bahamas together, so I know Amanda very well. I just want to apologize for any background noise you hear. There's a lot of wind here, so I hope that you're all staying safe from the perspective of the wind event that we're now having on top of COVID. I just wanted to say that my presentation is called Building Surge Capacity in Boston. I wanted to talk about the local level, where Amanda just talked about the federal and regional level, because I thought it was important that we talk about experience sort of in real time in the surge, and how a hospital, a tertiary care facility like Mass General has been watching other experiences, such as starting in China and Italy and our neighbors in New York, and learning from those experiences in order to build capacity. So my presentation is very much an experiential presentation, and it's built on the work of a lot of people at Mass General who are incredibly smarter than myself. Our surge response has been built by our hospital incident command team, and each division, the division of critical care, the division of medicine, throughout the hospital, each division, patient care services and nursing, has had leadership that has contributed to our surge and capacity response. And I think it's important to note, being an IMC webinar, that at each level of our hospital incident command and our capacity response, we've had individuals who are members of our global disaster response team, and who have deployed to disasters with International Medical Corps. And I think the importance of saying that is that, and I'll give an example, the Division of Medicine has set up respiratory infection clinics, and a lot of the leadership has been with our medical director, Lynn Black, who's deployed multiply with International Medical Corps. And the importance of saying that is that we're a tertiary care center, we're a high resource facility, but we really had to approach our response to the COVID pandemic with a disaster response mentality. And how do even an institution like ours, which is better resourced than most institutions, I would say, how do we take those resources, physical resources, consumable resources, and staff, and deploy them in the most appropriate ways to take care of the patients that we're going to need to take care of. So this is really experiential, and I'd love to hear what your experience is in various places that you've been seeing the surge. So we're all pretty familiar with the breakdown, I think, of the demographics of acuity of patients that are presenting both to testing and screening sites, but also to hospitals. So as we know, 40% of the patients basically have mild or no disease. They have symptoms, or they may be asymptomatic, requiring no hospitalization, no supportive care. These are what we call the walking well. These are the people that, maybe have a bad cold. And then there's the other 40% who are kind of walking the line. They have moderate case. They have the potential to require hospitalization. They may have other comorbid factors that put them at higher risk for potentially requiring hospitalization. And then there's the 15%. These are the people that we call severe, and these are the people that require oxygen therapy and likely will be admitted to the general care part of a hospital. And then there's the 5%, which I deal with, which are the people that are admitted to the hospital in critical condition and escalate very quickly to requiring mechanical ventilation. So our hospital has staged its response kind of based on these acuity categories. So I'll talk about each acuity category and how we've responded to the surge stepwise. We'll talk about the patients that are asymptomatic, that are presenting likely more for testing than for actual treatment. These are the walking well, but I would also maybe call them the worried well. So our hospital has developed alternate care sites, which I think all of you are familiar with in your work in disaster and surge. And alternate care sites have a multiplicity of goals, but the main goal is to minimize the exposure of staff and patients within the facility to people who are presenting with potentially the disease. Alternate care sites allow streamlining of the care of either rule out or COVID patients. They allow us to consolidate resources and offload the ED from having to take care of COVID patients. They allow us to redeploy staff from the hospital to areas where COVID or potentially COVID positive patients are presenting, and these staff members become subject matter experts in the care of COVID patients, which I'll talk about later is incredibly nuanced. It's a syndrome unlike any other syndrome I've ever seen before. All these staff become properly trained in PPE, and PPE is something that PPE is not static, it's a dynamic thing. PPE changes every single day. Every single day we get a different mandate or directive that we're to use a new N95 mask, to use a different type of PPE, and the staff that are assigned to these alternate care sites, which can be on-site of the campus of the hospital or off-site, and I'm going to talk about ones that are on-site of the campus of the hospital. These alternate care sites take these patients out of the population, they cohort them, and then they enable the care of other patients to continue because people don't stop having other diseases and other medical illnesses, as we know. And so examples of those are off-campus testing sites, on-campus testing sites, respiratory illness clinics, which I'll talk about, and then ED pathways for what we call persons under investigation, or people that potentially could be infected with COVID. So for patients with mild acuity, we've developed what's called a walk-in clinic or a surge clinic. So I'll give you an example. On February 26th, Biogen held a leadership conference at the Marriott Long Wharf in Boston. And this was really what we think of as the sort of epicenter of the outbreak of COVID in Boston. After the Biogen conference, which was the 26th, as I said, on the weekend, the 29th, people started to become symptomatic. Now, these were not the first cases of COVID in Boston, but this was the first surge of cases, potential cases in Boston. So that was the 29th. And then early that week, at the very beginning of May, so May 2nd and 3rd, people who had attended the conference started presenting to the emergency department of both Massachusetts General Hospital and Brigham and Women's Hospital, asking to be tested and quote unquote treated for coronavirus. These are people who had developed symptoms, fever, sore throat, cough, myalgia. At that point, we didn't have a robust testing capacity, so it was something that we were starting to build up. And we hadn't quite yet prepared our emergency department to absorb those patients. So very quickly, Mass General, by March 6th, developed what was called a surge clinic. In a surge clinic, we basically took the ambulance bays outside of the emergency room and turned them into testing facilities. So it took all of those Biogen employees that were presenting to our ED, potentially exposing our normal ED patients to COVID. It took them out of the general population, and it provided a place for them to be safely tested and isolated if they were experiencing symptoms of COVID. So our walk-in surge clinic is a screening and testing ambulatory site for patients who are symptomatic or asymptomatic. They also allow us to do preferential testing of employees who are referred by occupational health. The purpose of this is so that they can either safely return to their work duties or they can go home and self-quarantine. Patients in these places are educated about the recommendations for home quarantine, depending on their risk stratification, and they can be further educated about the virus. The surge clinics are located in what we call alternate care sites. So Amanda talked about alternate care sites being reconfigured, say, cancer hospitals, but we're talking about developing alternate care sites on the actual site of our hospital. So we use the ambulance bay for this. And the clinic could screen several hundred patients daily, rapid screening and testing. And the example was the Biogen surge. So the second category of patients, the 40% of patients who have a moderate case, so they have symptoms, but potentially they have something in their background that makes them at higher risk for decompensation, or they have more severe symptoms. They needed to develop a place where they could be seen and have a medical evaluation by a provider. And we didn't feel that it was safe to have them come to present to our emergency departments, present to our walk-in clinics, or present to our primary care providers that were on campus. So it had to be thought through, where do these patients go? So we developed a triage system, and it included the classic signs and symptoms that we see fever, sore throat, nasal congestion, shortness of breath, myalgias, loss of smell and taste, new onset of diarrhea, syncope, chest pain. I mean, the list kept getting longer as the presentation of coronavirus kept kind of becoming more expanded and nuanced. And then we also included in that the category of high risk. So patients that, as you can see, any of the risk factors that were listed here. So patients would call their PCP or have a virtual visit with their PCP, and they would say, I'm having a fever, and maybe in their record they are diabetic or they're over 70. And so their PCP would write them a referral to what we dubbed our respiratory infection clinics. So these were where moderately ill people could present. The appointments were same day, and they were PCP referred. These were decision points for testing, and they would create a disposition either to home with treatment and to follow up. So we followed up on a 2, 5, and 8-day follow-up course. Or if their symptoms were bad enough, they were given onward referral through a very specific pathway to the ED. It allowed a patient to be face-to-face with a provider who could identify whether or not the patient was at risk for decompensation. So they could measure their oxygen saturation, and they could examine the patient to see what their work of breathing was and kind of take a deeper dive into their chart to see what their risk factors were. We found out that oxygen saturation is obviously not an absolute value and had to be put in the context of a medical or clinical evaluation. It was really important for us to have eyes on these patients and not to be just doing virtual visits or to be just triaging patients to the ED based on symptoms. We really had to see them, and we really had to see, okay, hypoxia looks different in a patient with chronic COPD versus a patient who's coming in with COVID-19. As I said, we could evaluate the symptoms of chronicity, whether it was an acute onset or if it was more chronic. And the respiratory infection clinics, we developed the capabilities of being able to do COVID testing, but also to do chest x-rays, because that really provided a decision point where maybe the patient's level of hypoxia was not something that would make us want to refer them necessarily to the ED, but then they would have a bad chest x-ray with the typical bilateral opacification of atypical pneumonia, and we would then feel confident in our referral to the ED. Now, we could do point of care labs, which also allowed us to do some risk stratification with these patients. And then we decided whether or not these patients could be safely treated in the outpatient setting, which really was the goal, or if there was the patients that were on the razor sharp edge that needed to be moved onward to the ED. So it really helped us decompress the volume of patients that were presenting to the ED. About the first week of the respiratory infection clinic, so the clinic opened on the 15th of March, they were seeing several hundred patients a day. So you can imagine how much that offloaded the patient volume in the ED. So finally, we come to the category of the patients who, despite all of our interventions, we cannot keep them from being admitted to the hospital, who require a higher level of care. So those are the patients that are either going to go to the floor or the ICU. And so how to think about how to prepare ourselves for this surge of patients. How are we going to increase the capacity of our hospitals, specifically our ICUs, to take care of these patients so that the hospitals are potentially turned upside down, but not broken down? So a lot of work from a lot of people have gone into this at Mass General, and I'll give you an example. So on March 14th, we had 52 ICU beds open for COVID patients. The 2nd of April, we had 115 open, and as of the 8th of April, we have 230 beds open, with the capacity to expand if we were to go into a phase 4 emergency pandemic response to 334 ICU beds. And it's partially because we are a referral center for ECMO. We're a referral center for critical care just at baseline. So we do have this capacity, which I understand is made potentially a luxury of our institution, but it's also the creativity of a lot of people. So to give you an idea of what our inpatient surge has looked like. So on the right, you see the graph of over from the mid-March to last week, the rising number of cases in Massachusetts, and then the patient surge that we've experienced at the hospital. So at the beginning, low, and as of last week, we had about just under 250 admitted patients, and over half of those were in the ICU. So if you think back to the demographics on patient acuity, and you think, well, so 15% are admitted, and then 5% are in that critical care category, but the numbers don't necessarily play that out. So whether or not for us that's a factor of the patients that we receive are sometimes more critically ill than other hospitals, or whether or not that's people who are admitted through a general care pathway and slip off that orange line down onto the blue line, or require upward transfer of care into a higher level of care. It's hard to piece apart that data, but what I will say is that half of the patients that we have now in the hospital are in ICU beds, and almost all of those patients are on ventilators. So that gives you the sense of, when we talk about preparing for a surge, an institution like Massachusetts General Hospital can prepare for that surge, but you really have to think about how these outlying hospitals, which have sometimes one general ICU or maybe no ICU beds or maybe a handful of ventilators, how do we help them prepare their capacity to take care of the surge of patients? And so that's something that we're really closely looking at. So in terms of ICU surge planning, our goal was to increase ICU bed capacity to match the trajectory of the surge while maintaining specialty care beds. So people still have MIs, they still need cardiac surgery, people still have appendicitis and they rupture their appendix and they still need those taken out. So we had to increase our capacity for COVID while also maintaining a baseline capacity. We had to create a central point of contact to triage all these patients all over the hospital. So we've used nursing directors, medical directors of our ICUs. The goal was to cohort non-COVID patients and specialist providers in designated areas. So really heavily relied on our cardiac ICUs and our PACUs to decompress our other ICUs, so that those ICUs could take COVID patients, and other patients who were not COVID suspect patients or COVID positive patients could go and be safely cared for. Created alternate care sites to cohort critically ill patients. So we converted PACUs, we converted the pediatric ICU, and we've converted other general care areas. And to give you an idea, we've converted 2 oncology units to COVID care units. Initially, those were general care units, but we've had such a high influx of critically ill patients that we've had to then pivot those to become capable of taking care of ICU level patients. We've tried to admit and co-locate the sickest COVID patients requiring the most care, ECMO, CVVH, or that's dialysis for those of you that you don't know, or extensive proning on specific units, or what we call resuscitation units that are trained in the care of those patients, so that we can laterally transfer patients who are still critically ill but recovering from COVID to lower acuity ICUs or some of the general care areas that have been converted to ICUs. We've established a pathway for suspect COVID-19 patients who have another ICU need. So those surgical patients who also came in from the community and maybe had a community exposure, plus it was the worst day of their life, they also ruptured their appendix. And this has really been the crux of things. We've redeployed nurses from non-critical areas to be extenders or resource partners for ICU nurses. So our nursing staff has been incredibly flexible in terms of redeploying themselves throughout the hospital and allowing us to take those nursing staffing ratios, which are generally 1 nurse to 4 patients in our general care areas and 1 nurse to 1 or 2 patients in our ICUs, and extend or flex those staffing ratios in a way that maximizes nursing resources, but provides safe patient care. So an example of that is we use Epic, and so all of our nurses are trained in Epic. So our med-surg nurses or our general care nurses are pretty adept at handling a lot of information and charting in Epic, while our ICU nurses might be able to be managing the ventilators. So an ICU nurse plus a nurse extender can take care of 3 patients instead of just 2. We've deployed, each unit has a infection prevention and control focal point, and they are up to date on the best practice and guidance for PPE and staff protection in terms of occupational health. We've created special teams, and this is exciting for those of you who like procedures and things, to offload some of the care of the critically ill. So we have the COVID-based rapid access team, or the COBRA team, and this is a new team that will come in and assist you with placement of lines and other ICU level procedures, so that the providers can continue to focus on taking care of the patient. We also have a point of care ultrasound team or teams that can come around while we don't necessarily feel that echocardiography is safe to deploy to all patients at this point, because that creates a point of potential exposure. Point of care ultrasound teams are great because they are teams that can go around and do ultrasounds on the COVID patients and provide real-time data to make clinical decisions. And then another thing, as I had mentioned before, is that we are highly resourced. We have staff, we have things, but we've developed a system to be able to do interagency lateral transfers of critically ill patients, so we can offload overcapacitated rural hospitals or some of our satellite medical centers. So as I talked about, we have the capacity to really wildly expand our ICU beds. And that's not just for us, that's to create rooms so that we have places that critically ill patients from around the broader community can go. You know, as we all know, the sickest patients are sometimes the fewest patients, but often require the greatest amount of resources. And this is really where I've had to come at this from a disaster medicine perspective. How in our clinical decisions do we maximize the use of our resources for the greatest number of people? And sometimes in the ICU, when you're thinking about one critically ill person, you're looking at one person who needs potentially to be intubated or potentially needs another life-saving maneuver. How are we making those decisions? And how are we adapting our care in order to be able to provide the greatest care to the most number of people? So these are some of the limited ICU resources and some of the adaptations that we've been thinking through. I talked about clinical staff with critical care and emergency airway experience. I mean, we have a robust anesthesia staff that's been able to help us with our intubations and ventilator management. But how do we best figure out how to deploy and redeploy and train on the fly our entire staff to be able to care for these patients? One thing that we've heard about a lot of is how do we maximize the use of ventilators, because the treatment really for coronavirus for the sickest patients is oxygen. So that's the treatment. Then how do we maximize our capacity to deliver oxygen to the sickest patients? So we think about how we use and deploy ventilators. We also have to think a lot about, before we get to the point of a patient being on a ventilator, how do we mitigate that so that they potentially don't have to be intubated if it's avoidable? Or how can we postpone it safely to the point where they do need to be intubated? We've had to figure out how to use our negative pressure rooms appropriately. Even our institution can't necessarily build on short notice more negative pressure rooms. One especially important thing to consider during this surge of patients, and we've, as I said, had the benefit of looking at the experience of those that have gone before us and learning from that experience. So there's a real push for people to be able to provide treatments, medicine that is going to be the sort of cure-all, the one-size-fits-all cure for COVID. Maybe not cure, but something that will help us to get these patients better. And the syndrome of illness that is coronavirus has really eluded some of our thinking and some of our interventions. So an example is, we treat all patients that come in, we treat with antibiotics, ceftriaxone and azithromycin, for potentially overlaying community-acquired pneumonia. So we've had to think about, in the event that, we run out of any of these antibiotics, is this best practice? These patients are highly inflammatory and they have the potential to clot and develop pulmonary embolisms and to develop microclots in places we can't even see. And so we're wondering if that's part of the constellation of things causing their low oxygen saturation. So we've put the patients sometimes on heparin drips so that we, a blood thinning medication, so that we can prevent them from developing those clots. Well, we've had a heparin shortage for a very long time, and a lot of our supplies of heparin get made in China. So we've had to think about other ways that we can walk around having to use this medication. So we've had to think of a lot of ways to use our medications appropriately and wisely, and then we have to, in that, extrapolate into the future. Because as I've said, Boston, we haven't hit our surge yet, so we're waiting for it. So we need to know that we have what we need on hand when we do hit it. Other things include dialysis, any kind of diagnostics, respiratory therapists. That we've never been more grateful for our respiratory therapists than we are now. And then personal protective equipment, which I know that IMC already had an entire webinar on that, so I won't get into how we're using all of our resources to extend our supply of personal protective equipment as we prepare for the surge, which we're told is probably coming in the next week or so. So, and I'm going to finish here, but I just want to put in a plug too. As the surge is upon us, I think we need to really be mindful of thinking about, even at the highest levels of care in the ICU, who our patient populations are, and really notice what the disparate effects of this disease on particular populations are. In Boston, we've had clusters of COVID positive patients that have become critically ill come from certain neighborhoods, so Chelsea and East Boston, which are more demographically Latino, Latina, and Hispanic, and that we need to work. We see this high degree of disparity, but we need to work with our partners on different levels of the system to be making sure that those disparities are noticed, and so that we are not just seeing the surge as a surge of patients coming from areas, and we're not speaking out about why they're coming from those areas, whether it's the messaging isn't getting to them, whether they're not getting to the testing and treatment soon enough, whether social distancing isn't working in those communities. So I would just say that even if you're operating in the ICU, you need to be operating on all levels of the hospital and healthcare system. So with that, I will close there and I will turn it back over to Ryan.
Great. Thank you, Lindsay, for sharing your experience and MGH's experience and creativity to increase capacity for COVID and non-COVID patients. I would just like to extend a huge thank you to our guest speakers, to Amanda and Lindsay for taking the time to plan these presentations around your clinical shifts, and also for sharing your expertise on medical surge with all of us. Another special thanks to our colleagues in Learning and Development for your support on the production of this webinar. So this was the last webinar in the COVID Learning Series. To look back at where we've been, we started with perspectives on the COVID-19 pandemic, then went on to look at mental health considerations for healthcare workers, and we closed with the Nurses Forum, 3 sessions from frontline healthcare workers on PPE and monitoring, isolation and quarantine, and this final presentation on medical surge. All of these recordings can be found on the International Medical Corps website. Please share widely with anyone who may be interested in this series. This concludes today's webinar. Thank you again for joining us, and our best to you, your families, and your colleagues. Take care.